So just to introduce myself for those on the call, I'm Tanya Rizzo. I'm covering for Dr. Elin Zhang, who's our coordinator of our inpatient med peds team for the residency. And it is my pleasure to introduce Dr. Jing Chao, who is a clinical associate professor and endocrinologist at the UW, where she acts as the director of the UWMC Montlake inpatient glycemic team. She's an expert in the management of the most challenging cases of inpatient hyperglycemia, including severe stress-induced hyperglycemia, steroid-induced hyperglycemia with varying doses of steroids, and tube feed and TPN-induced hypoglycemia, superimposed on type 1 and type 2 diabetes, as well as pancreatic diabetes and CF-related diabetes. So welcome and thank you so much.
Thank you for the introduction. Good afternoon, everyone. Thank you all for inviting me to give this talk. In the next hour, I will review the most pertinent clinical pearls for managing inpatient hyperglycemia with you. Many of the concepts covered in this lecture will be useful in the outpatient settings as well, but there's definitely more of an inpatient focus. I will try to save 5 to 10 minutes in the end for questions. But if we don't get to answer all of your questions because we ran out of time, you can feel free to email me if needed. So very quickly, let's review our objectives for today. We will first define the recommended glycemic targets for the hospitalized patients. We will spend a few minutes reviewing history taking, which is pertinent to providing good care. The first topic to review is the management of basal bolus insulin, which is important for both outpatient and inpatient practice. Next, we will review the transition from IV insulin to subcut insulin. You will likely need to do this regardless of your specialty. Clinicians at the UWMC Montlake do this very frequently. And finally, we'll review the management of tube feed and TPN-induced hyperglycemia if time permits. My suspicion is that we probably will not get to that today. All right, so let's start with the glycemic target in hospitalized patients. The American Diabetes Association has defined hyperglycemia in the inpatient setting as having a blood glucose of over 140 milligram per deciliter. They recommend initiating insulin for patients with persistent blood sugar over 180. These recommendations have a grade A level of evidence, which is very high. Inpatient hypoglycemia is defined as having a blood glucose of less than 70. I will urge everyone to try to avoid calling it blood sugar hypoglycemic unless it's truly below 70. For patients who are not on an anti-hyperglycemic agent, especially in many young or middle-aged women, they may have a fasting blood sugar in the 50s, 60s. As long as they are asymptomatic and not meeting the Whipple's triad, these endogenous blood glucose levels should be considered normal and does not require any further workup. Since 2019, the American Diabetes Association has redefined hypoglycemia on the inpatient setting with 3 levels of severity. Level 1 hypoglycemia is defined as having a blood glucose less than 70 and above 54. Level 2 hypoglycemia is having a blood glucose below 54. And level 3 hypoglycemia is the one that we really earnestly try to avoid, which is defined by having severe cognitive or physical impairment in the setting of a true hypoglycemic episode, regardless of what that blood glucose reading is. And that results in requiring assistance of a third party to treat the hypoglycemia. So that's level 3 hypoglycemia for you. All right, looking at the inpatient glycemic targets more closely, the glycemic goals within the hospital have evolved over the last 20 years. The initial target of 80 to 110 milligram per deciliter was based on a 42% relative reduction in the ICU mortality in critically ill surgical patients, and this was from the Vandenberg study published in New England Journal of Medicine in 2001. However, a meta-analysis of over 26 studies, including the largest and most well-known one called the NICE Sugar, demonstrated that there's an increased rates of severe hypoglycemia and mortality in tightly versus moderately controlled blood sugar in the patient cohorts. This new evidence from 2009 helped establish our current inpatient standards of care. Recommended blood glucose target for most critically ill patients and non-critical patients is now between 140 and 180. and more stringent target of 110 and 140 to 140 has been proposed for the following patients: cardiac surgery patients, patients with acute myocardial infarction, and also in the context of acute stroke or TIA. So this is provided that we need to keep in mind that when we set any glycemic target, we need to be able to achieve that without inducing significant hypoglycemia. So while the current recommendation is for a tighter glycemic target of 110 to 140 in patients with acute stroke, the SHINE trial published in 2019 showed that patients presenting with acute stroke do not achieve a greater functional improvement 90 days after their stroke when their blood sugar is targeted to a tighter range of 80 to 130. And this is when compared to patients whose blood sugar is targeted to the standard of 80 to 179. In addition, in the SHINE trial, they found that the group whose target blood sugar is set to the tight control of 80 to 130 developed more severe hypoglycemia of 2.6% during the treatment period versus no hypoglycemia at all in patients receiving the standard care. Therefore, the jury is still out regarding whether patients presenting with acute stroke should really be targeted to such a tight glycemic target of 110 to 140. The bottom line is patients with a history demonstrating successful tight control in the outpatient setting who are also stable may be maintained at a target below 140. On the other hand, patients with limited life expectancy should have their glucose target adjusted to a higher range to reduce possible hypoglycemia. Clinical judgment should be used to determine the appropriate inpatient glycemic target for your patients, and this should be done on a day-to-day basis on the inpatient side. The bottom line from a very complex body of literature is that both hyper and hypoglycemia should be avoided because they are not good. All right, so let's move on to history taking. Okay, so this slide presents you the history items provided in the usual order that we write our HNP. The first one that I have up here is age. If patient is very young and non-obese, this patient is likely to have type 1 diabetes or LADA, standing for latent autoimmune diabetes of adult. This should always be considered with the duration of diabetes. So for example, if you're seeing a patient who's in the mid-50s and the patient tells you, doctor, my diabetes was diagnosed 25 years ago, and I have been on insulin ever since the onset of my diagnosis, you should still consider the possibility of type 1 diabetes or LADA in this patient, even if the patient's labeled as having type 2 diabetes. And then the other reason that the duration matters is because if patient has had a long duration of poor control, that raises the likelihood of complications, which may or may not have been diagnosed. Next, we consider the type of diabetes that patients have. This greatly affects the type of anti-diabetic medications that you're going to use to treat the patient, as well as determining the proper dose of insulin that you should start the patient on. And then, does the patient has a history of DKA? If positive, again, it raises the possibility for type 1 diabetes or LADA, but you need to be aware that there's also a diagnosis called ketosis-prone type 2 diabetes. Since the COVID pandemic hit us in 2020, we have seen a rise in DKA episodes in patients with type 2 diabetes who present with acute COVID infection requiring hospitalization. The exact mechanism for this is not entirely clear yet, but we just know that this does happen. Also, if patient has had that DKA in the past and is now having his or her blood sugar running at 350 or greater, you do need to be actively thinking about checking that chemistry panel and NI gap, and also maybe consider urine ketones or serum ketones to make sure that patient is not having DKA, especially if patient's also symptomatic for it. Next, we have micro and macrovascular complications to consider. These complications give you an idea of patient's control of blood sugar at home. If a patient has had multiple complications with limited duration of life expectancy, then you should also actively think about modifying the glycemic target to a little bit of a higher range, both on the inpatient side and outpatient side. And then we get to the section of anti-diabetic medications. For this section, in addition to getting the medication doses and frequency that the patients take the medications, I would urge you to think about, do these medications make sense? Is there a good reason that your patient with type 1 diabetes is taking an oral anti-diabetic medication that is not metformin? And is it safe for someone with type 1 diabetes to be on an SGLT2 inhibitor? And if patients are on insulin, does the way they take their insulin make sense, or do the doses add up? And then compliance will be the next thing to assess now that you have the medication list down. If a patient tells you that he takes Glargine 30 units at bedtime and Lispro 10 units with each meal, but then with further questioning, you really find out that patient is skipping the Glargine every other day because of hypoglycemia, you probably do not want to start him on his quote-unquote home regimen of Glargine 30 units every night in the hospital. To assess the control of blood sugar at home, in addition to the blood sugar values that patients report to you, a very effective way of monitoring or assessing how reliable or how compliant a patient is assessing how frequently the patient's monitoring the blood sugar at home. So nowadays, we have more and more patients using the continuous glucose monitor. There remain a fair portion of patients using finger stick blood sugar using glucose meter. So either way, you should ask how often, how many times your patients check the blood sugar at home, because the more times that the patient monitor, that means the patient's keeping in mind that of his or her diabetes care. And those kind of patients who are monitoring frequently are likely to be more compliant. Lastly, you may want to use the A1C to assess patients' blood sugar control at home, but you need to recognize that A1C has its own pitfalls, particularly for patients who are chronically ill, patients who are being admitted to the hospital frequently, or patients who have a hematologic or oncologic conditions. I usually pay attention to patients' weight and BMI. I use a weight in kilogram to gauge if the insulin regimen that I'm about to start seems to be appropriate or maybe overly aggressive. A patient with a BMI in the obese range is more likely to have type 2 diabetes, even though that's definitely not absolute in this day and age. And also, BMI in the obese range means that the patient could require more insulin to bring the blood sugar down. Presence of renal insufficiency means that decreased insulin clearance, which is mostly by the kidney, with one exception that insulin degludec is neither cleared renally nor hepatically. Degludec is cleared enzymatically by quote unquote some magic reaction. So, but other than degludec, all insulin are cleared by the kidney. So if your patient admitted to the hospital is suffering from AKI, you need to proactively think about reducing the insulin doses. Patients who drink alcohol excessively and use insulin are at a high risk for hypoglycemia because alcohol diminishes the liver's ability to respond to hypoglycemia with the appropriate glycolysis and gluconeogenesis. Next, let's take a look at hemoglobin A1C and why we shouldn't be faithful believers in A1C. There are times that A1C will fool you, and you need to be careful to not fall for the falsely high or low A1C. This is especially true on the inpatient setting. A1C will look better than patients' actual glycemic control when there is blood loss, faster red blood cell turnover, for example, when patients are getting erythropoietin, or when the red blood cells are not theirs, such as in the context of a transfusion. The reason for A1C to look falsely low is because what we're measuring is the advanced glycation end products that are tagged on the surface of patients' red blood cells as a result of their red blood cells being immersed in glucose in the blood. So that induces the chemical reaction resulting in the measured A1C. And there are also times that patients' A1C will look worse than their actual blood glucose control. This is more rare compared to A1C being falsely low. But an example of this will be your patient with iron deficiency anemia who now starts to take the iron. That would actually potentially make A1C falsely high. And another example is uremia. So you should also watch out for variant hemoglobinopathy, which leads to inaccurate A1C in both ways. So an example of that is sickle cell anemia. All right, so we know that it's not just our trust issues, but it's because we know how to gauge the accuracy of A1C. I want to demonstrate the importance of history taking using an example. This is an actual patient that I had taken care of in the past. Based on the good history taken here, my assessment, I will tell you my assessment. So first of all, this is a 33-year-old female with type 1 diabetes diagnosed at the age of 8 years old. She does not have known macrovascular complication, but she does have documented diabetes neuropathy, blindness from retinopathy, severe gastroparesis, has undergone gastric pacer and J2 placement, has also developed hypoglycemia unawareness. Her weight is 66 kilograms, BMI is 27, putting her in the overweight range. She tells you, my home regimen is Glargine 10 units twice a day. I take Lispro 1 unit per 10 grams of carbs, Lispro high dose correction AC before meals. So in a few slides down the road, I will show you what the carb ratio and correction doses mean, but this is what she's telling you. So everything sounds sophisticated and good, but in a moment, we'll discuss whether that's really good or not. This patient tells you, my blood sugars well controlled at home, quote unquote. And you look at her A1C, 7.4 in October 2015 with a hemoglobin of 9.9, 8.1 in July 2015 with a hemoglobin of 9.6. At a very quick glance, if you don't interpret your A1C with a concurrent hemoglobin, you might be led to think that, oh, maybe this patient's glycemic control is not too bad at home now. But you need to realize that after comparing that to the moderate anemia that she has, her true A1C is likely much higher than what's shown here. All right, so based on the good history that I have shown here, my overall assessment of this patient is that this is a young female with long-standing type 1 diabetes who has had very poor control of her blood sugar over a long period of time. This is evident in that she has all of the microvascular complications that one can possibly think of under the sun. Her weight and BMI, while they are on the higher end, are still consistent with that you may think of for someone with type 1 diabetes. And her home insulin regimen makes absolutely no sense. Why is that? Her basal insulin is 20 units a day. So 10 units twice a day equals to 20 units once a day. So 20 units a day is equal to 0.3 units per kilogram of body weight. Will a type 1 patient need this much basal insulin? I guess it's possible, but this certainly is on the higher end for someone with type 1 diabetes. Her carb ratio falls in the range of an intermediate strength, quote unquote intermediate, but her correction does not match because she reports taking a high dose correction. So overall, her insulin regimen that she reported really does not make sense or does not add up. And we already discussed about her A1C. So now, after analyzing the case, do we really trust her when she says that her blood sugar is well controlled at home? I think not. All right, now we will briefly discuss the fundamental concepts in diabetes management, the basal bolus insulin. So when patients are admitted to the hospital, what do we do with their non-insulin anti-hyperglycemic agents? The answer to that question is we routinely stop all oral agents when patients get admitted to the hospital due to the literature suggesting that insulin is the safest on the inpatient side. This remains the guideline from ADA at this time. When no more contrast diet or procedure is planned, and also that the discharge is anticipated in 1 to 2 days, it is reasonable to restart an oral medication again. There is currently no evidence supporting the use of the newer ultra-long-acting basal insulin in the inpatient setting. Namely, these ultra-long-acting insulin are insulin degludec, better known as Tresiba, and insulin Glargine U300, better known as 2JO. Both insulin degludec and Glargine U300 are not available on our hospital's formulary, and I also suspect that Valley Medical Center do not have this formulary either. All right, so I have more slides on insulin degludec coming up, and we will discuss how to manage this insulin a few slides down. Very quickly on the Dpp4 inhibitors, a recent randomized pilot study in the medical surgical patients showed that the Dpp4 alone, or in combination with a basal insulin in the study's Glargine, has been shown to be well tolerated and led to similar glycemic control as well as frequency of hypoglycemia on the inpatient side. Therefore, if you need, you may use the Dpp4 inhibitor in the hospital. However, FDA recommends discontinuing the saxagliptin and alogliptin in patients with heart failure. Several studies show that the GLP-1 receptor agonists do not cause hypoglycemia, and they are promising substitutes for insulin, sulfonylurea, or metformin. And with the latest data showing that the GLP-1 receptor agonists lead to renal protection and cardio protection, the ADA has actually modified its outpatient guideline to consider these second-line agents in the appropriate patient groups who are at a higher risk for kidney disease or cardiovascular events. So one study has randomized 54 patients to either what's called Basal plus Regimen, which is Basal plus Correctional Insulin, or randomized to the Basal plus and dulaglutide. This study was conducted over 7 days. Blood sugar was checked before and after each meal. The group using the dulaglutide showed a significantly higher percentage of blood sugar in the target range of 100 to 180 compared to the insulin alone group. And then there's also a lower incidence of hypoglycemia in the dulaglutide arm. Lastly, the dulaglutide arm also led to lower doses of insulin needed. Another multi-center randomized trial enrolling 150 patients, randomizing to exenatide alone, exenatide plus a basal insulin, and insulin alone with basal bolus insulin. But this study showed that a higher proportion of blood sugar in the target range of 70 to 180 was seen in the dulaglutide plus basal insulin group. There's no difference in hypoglycemia, and however, there are definitely more GI side effects seen in the two groups using the exenatide. So in summary, GLP-1 receptor agonists seem to be safe for use inpatient, but the biggest thing is the GI side effects that's associated with this group of medications. The reported incidence of GI side effects is anywhere between 12 to 22%. And we know that Ozempic is actually the far more potent agent in this group, and the reported incidence of GI side effects on Ozempic is also a little bit higher. So when you are actively trying to advance patient's diet in the hospital and discharging the patient, using a GLP-1 receptor agonist may actually get in your way of advancing the diet and discharging. So it's probably better to hold off on them until the time of discharge. And then what about the SGLT2 inhibitors? The SGLT2 inhibitors are increasingly used both inpatient and outpatient due to studies demonstrating its benefit in the cardiovascular and renal protection. In terms of cardiac outcomes, optimizing heart failure and prevention of hospitalization due to heart failure exacerbation have been the driver of the favorable composite cardiac outcome. So when using these agents, you need to actively monitor for euglycemic DKA. There's also other side effects that you should counsel your patients, such as genital mycotic infection, urinary infection. But the euglycemic DKA is associated with a higher morbidity and also mortality. So that's the one to look out for, especially on the inpatient side. Patients who are especially high risk for DKA include those with severe illnesses, known history of DKA, undergoing prolonged fasting, or surgical procedures or general anesthesia. And also, there is no consensus among the endocrinologists about whether patients with type 1 diabetes should be treated with SGLT2 inhibitor. So patients, when they exhibit symptoms and signs of DKA on the SGLT2 inhibitors, you should readily check their serum ketones and treat the DKA if it is confirmed. This slide is an older slide showing you the approximate pharmacodynamic profiles of insulin used on the inpatient side. We have the rapid-acting analog aspart lispro. Their duration of action is generally 4 to 6 hours in patients with normal renal function, and there's a perceived peak of this insulin. Regular insulin is used less and less subcutaneously, especially in the hospital. On the outpatient side, due to cost, some patients with type 2 patients may still use this insulin, but as you can see, it's not entirely physiologic when you try to use that as a mealtime insulin because it lasts 6 to 10 hours and also has a pretty pronounced peak. You have NPH being one option for your basal insulin. This insulin textbook says 12 hours of duration of action, but there's a slight tail end to this insulin that drags out to maybe 14, 16, 18 hours with much diminished action during those hours. And then you have extended zinc. That's the detamir at lasting 18 to 24 hours. And then lastly, the most commonly used basal insulin in the hospital is the Glargine, which has a duration of action of 20 to 24 hours. And yes, you can see here on this older slide, the pharmacodynamic of this Glargine is actually pretty flat. And then we'll see an updated slide coming up here. All right, so year 2021, we have greatly expanded our armory of our basal insulin. So we have already covered NPH, insulin Glargine U100, insulin detamir. The new kids on the block since 2016, really not too new anymore, are insulin Glargine U300 2JO, which lasts about 32 hours. And then also insulin degludec, Tresiba, better known as Tresiba, available as both U100 and U200. This lasts 36 to 42 hours. There has been an insufficient amount of evidence to demonstrate their safety and glycemic control for inpatient use at this time. But Tresiba degludec has been shown to lead to significantly less episodes of hypoglycemia, both nocturnally and throughout the entire day compared to Glargine. I have previously mentioned that Glargine has a relatively flat pharmacodynamic profile on the previous slide. So Glargine is in navy, the navy curve on this graph. You can see that compared to the lime green curve, which is insulin Glargine U300, and the beige curve, which is insulin degludec. Compared to these newer, longer lasting basal insulin, Glargine really is not that flat in the action profile anymore. Okay, clinically, what I have observed is that Glargine U300 remains very similar to Glargine U100. And when you have patients who are taking Glargine U300 as outpatient admitted to the hospital, it's perfectly fine to do a one-to-one conversion from one to the other. I haven't really run into any issue, but of course you need to gauge whether a patient's baseline basal insulin is a reasonable dose. What poses a challenge is insulin degludec, which I'll spend a few minutes on the next couple of slides. So what you should know about insulin degludec as a sophisticated internist, degludec has an extremely long duration of action of up to 42 hours. and a half-life of 25 hours. If you consider insulin glargine U100, better known as Lantus and Basal, Glargine U100 used to be the longest acting of basal insulin that we had before we have insulin degludec and Glargine U300. Glargine U100 has a duration of action of only 20 to 24 hours, and the half-life is only 12 hours. As you can see, degludec lasts almost twice as long as Glargine U100. Given its long duration of action, you can imagine that there is a significant amount of overlap when you give each dose of a degludec every day, daily, which is the box instruction. Okay, so these overlapping doses eventually reaches steady state. So I will jog your memory now by taking you back to pharmacology that you learned in medical school. So the first question is, how many half-lives does it take for any given drug to reach its steady state? The answer to that is 3 to 5 half-lives. Second question is, how many half-lives are needed to pass before a drug gets washed out or eliminated from the body? The answer to that is 4 to 5 half-lives. How long is 3 to 5 half-lives for insulin degludec and insulin glargine U100? So quickly calculating this in your head, that is degludec for degludec, it's 75 hours to 125 hours. In other words, 3 to 5 days. So it takes that long to onboard and offboard degludec. This is a trick question about Glargine U100. And the reason it's a trick question is that Glargine U100 never reaches a true steady state. So each time you give the dose goes on, dose comes off in the expected time period without any issue. So on this slide, I have Glargine represented on the top part of the curve, where you see that each dose becomes effective and wanes in a 24-hour period. And then at the bottom of the slide, you have insulin degludec represented with each dose given daily, building on top of the prior dose and achieving steady state in about 3 to 5 days. The reason the pharmacokinetic and pharmacodynamic properties of degludec matter so much is that when you admit a patient who last took their degludec dose earlier in the day, same day or yesterday, you can't simply replace the degludec using the same dose of Glargine by using a 1-to-1 conversion, because there's still residual amount of degludec that you need to account for. Giving the same dose of Glargine within 24 hours of the last dose of degludec poses a theoretical risk of hypoglycemia. When you admit patients on degludec, I have 2 recommendations for you to consider. The number 1 option is that you must take the remaining degludec on board into consideration, and this can be done by calculating the half-lives that have elapsed. Subtract the amount of degludec that is still on board from the total basal requirement and give the remaining portion as Glargine for the day. And you need to do that for 3 to 5 days until degludec is mostly washed out. Option number 2, you may opt to continue patients' home degludec dose as long as their glycemic control at home suggests that their basal insulin dose is reasonable. For most patients, their insulin degludec dose represents their true basal insulin requirement because patients are less tolerant of having degludec covering their food intake. So this should be a pretty safe option, provided that the home dose is a reasonable dose. For the small percentage of patients whose degludec really is covering prandial intake, then you definitely need to consider ways of cutting back on that if patients' intake in the hospital is not the same. So this option number 2, relies on patients bringing in their own degludec from home, which may or may not happen all the time. In addition to the complexity in offboarding the degludec at the time of admission, restarting degludec at the time of discharge also means headache, because the patient may end up spending 2 to 3 days with hyperglycemia until the steady state is reached. This is definitely more problematic in patients with type 1 diabetes, because we have had some patients with type 1 diabetes going into DKA as a result of degludec not reaching the steady state. So make sure you give proper instructions on treating the hyperglycemia at the time of discharge. All right, so now we have come across the big topic, which is multiple daily injection regimen. When should the multiple daily injection insulin regimen be started? For patients who have type 2 diabetes, when the patients are on once a day or twice a day basal insulin without prandial insulin, and the patients keep having overnight hypoglycemia or hypoglycemia whenever they don't eat, followed by postprandial hyperglycemia, those patients need to be started on multiple daily injection. All patients with type 1 diabetes, most patients with cystic fibrosis related diabetes, and patients with pancreatic diabetes with very little endogenous insulin secretion, these patients need to be on multiple daily injection regimen from the get-go. How to start the basal insulin? Textbooks would suggest that you should start them on 10 units per day or 0.1 to 0.2 unit per kilo per day, and then adjust the basal insulin by 10 to 15% based on their blood sugar after adding the initial dose every 2 to 3 days. And what about nutritional insulin? If patients' meal intake is lacking, very low or inconsistent, especially in the hospital, we typically will give correction rapid acting insulin only. We don't add the fixed dose prandial insulin. But when patients are consistently eating, you have two options. Number one is you can give patient fixed doses of nutritional insulin. The more sophisticated options using the carb ratios is for most people with type 1 diabetes, patients with pancreatic diabetes, and then the special category is CFRD, cystic fibrosis related diabetes. These patients usually are set out to eat a goal of 6,000 calories a day. So, and another characteristic to these patients is that they may eat a highly variable amount of carb every time they eat, and they may eat multiple times in a day. So those kind of patients really can't get away with fixed doses of nutritional insulin, and that's why they need the carb ratios. And lastly, another situation to consider is if the patient demonstrates wildly variable carb intake to result in a discrepant amount of nutritional withdrawal every meal, then those patients will be candidate for that. So what constitutes a good multiple daily injection regimen? For the basal insulin, typically the basal insulin to rapid acting insulin ratio is typically 50-50. Or also very often 40% basal, 60% rapid acting. Less frequently 60% basal, 40% rapid acting. The last case, 60 to 40, is more applicable if patients' intake overall is lower in carbs. An exception to this rule is that when patients are placed on steroids, their prandial to basal insulin requirement gets skewed to 70% prandial and 30% basal. So at this moment, I want to stop and give you a word of caution. As a sophisticated clinician, you need to know that the sole use of sliding scale insulin in the inpatient setting or also on the outpatient setting is strongly discouraged. And in fact, you should never again say sliding scale after hearing from me today, because what that suggests is that you are only adding a scale of insulin to match patients' hyperglycemia, and you are not actively reviewing patients' blood sugar and incorporating the amount of correctional insulin used from the quote-unquote sliding scale to make a fixed dose insulin regimen in the hospital or on the outpatient setting. And that's been shown to lead to very poor glycemic control. Never say sliding scale ever again. Okay, with the concept of correctional insulin, which is the term that we use, the idea of that is that you add scale to correct the high sugar, but then you will actively review patients' blood sugar and how much correctional insulin patients required on the inpatient side every day, at least every day, on the outpatient side every visit, and then actively build that amount of correctional insulin needed into patients' fixed doses of MDI regimen. We do not want a sliding accident. Never say sliding scale ever again. Okay. All right, so as promised, I want to go over the endocrinologist lingo about carb ratios, correction factors. So carb ratio simply means you give 1 unit for however many grams of carbs that patients are consuming. We do have this as available orders through EPIC at University of Washington Medical Center, Montlake Northwest, and Harborview. So what is considered strong versus soft carb ratio numbers? So I have a list here of some of the common carb ratios: 1 per 20, 1 per 15, 1 per 12, 1 per 10. All of these are very common. Generally, 1 per 15 to 1 per 20 or something higher is considered a soft carb ratio. 1 per 12, 10, 8, those are considered your intermediate strength. And then anything smaller than that, so like 1 per 7, 1 per 5, anything smaller than that are considered strong or high dose carb ratios. Okay, so take an example with a 60-gram carb meal. If you prescribe 1 per 20, that means that the patient will then get 3 units of rapid-acting insulin for a 60-gram meal. For 1 per 15, 4 units, 1 per 12, 5 units, 1 per 10, 6 units. Now you get the idea that the smaller the carb ratio, the greater amount of insulin that they get. I want to show you a very handy rule, the 500 rule. If you take 500 divided by the total daily dose of insulin, which means all of the insulin units added up in a 24-hour period, that gives you an estimate of patient's carb ratio. So if you really need to start someone on the carb ratio, whether it's outpatient or inpatient, this gives you a good starting point. You probably will also want to look at some of the other things to make sure, double check on the math. But this definitely is going to be very handy if you do ever need to start a patient on carb ratio. Next, correction factor, also known as insulin sensitivity factor. You most likely have encountered this in patients who are using an insulin pump. But even if you do not manage patients on insulin pump, this is a very useful concept to have. All that this is saying is how much does the blood sugar drop when you give 1 unit of insulin to the patient. Okay, so soft versus strong correction factor. So something like 1 unit bring down blood sugar by 75 or 1 unit bring down blood sugar by 50. Those are considered the soft or low dose correction factor. 1 per 35, 1 per 25, these are considered intermediate. So if your insulin 1 unit can only bring down the blood sugar by 20, 15, 10, that means the patient is highly insulin resistant, not really responding to the insulin very well, and those are considered high dose corrections. So here's the correction scale at University of Washington. So we see the low dose correction scale, medium dose correction scale, and high dose correction. And I have computed the correction factor for you at the bottom. So you get an idea of what is high, medium versus low. So you can use that scale both on the inpatient and outpatient side to correct the patient's hyperglycemia, and that's actually very useful. Next handy rule to keep in your pocket, the 1500 and 1800 rules. The 1500 rules says that if you have a type 2 patient, you take 1500 divided by the total daily dose of insulin. That can give you a good estimate of the patient's correction factor if patients have type 2 diabetes. If you have a patient with type 1 diabetes, you will do 1800 divided by the total daily dose. Keep in mind that once you get a correction factor that's around 10, 12 or lower, the 1500 and 1800 rules become a little bit less accurate. So once again, this is something for you to kind of consider and then double check to see if whatever you're prescribing on the inpatient or outpatient end makes sense, or when you try to prescribe a correction scale, where to start. All right, very quickly, I want to demonstrate the concept of adding nutritional insulin to a patient who's previously only on basal insulin alone. This is a true patient, Mr. RR. You have his blood sugar data shown here. He is on Glargine 24 units given once a day in the morning. As you can see, the blood sugar is tightly controlled all day on the first day until bedtime, when the blood sugar rose from 93 before dinner to 220 at bedtime. He got Lispro 2 units. Well, okay, next morning, fasting hypoglycemia, still given 24 units of Glargine. What would you do? So this is the perfect example and simple example of showing you that this patient needs multiple daily injection. What you should do is you dial down the basal insulin by 10 to 20% to allow room for the addition of nutritional insulin. The only time that Mr. R has demonstrated to needing the nutritional insulin is with dinner, because his blood sugar rose significantly after dinner. So how do I estimate how much nutritional insulin to start? The best way, well, one way to do this quickly is you take the total daily dose of patient's insulin requirement in a 24-hour period. If the total daily dose of insulin is between 0 to 40 units, this patient, by UWMC standard or in general, needs a quote-unquote low dose correction. 0 to 40 units, low dose correction. 40 to 80 units a day, medium dose correction. Over 80 units a day, high dose correction. So next, you place the high sugar on the correction scale that's appropriate for your patient. For Mr. RR, this is a low dose correction translating into Lispro 2 units. So Lispro 2 units or maybe 3 units is a very appropriate place to start for the dinner. Okay, so that's one way to manage this case. Next, we have Miss JA. She is a 48-year-old female with CFRD. Weight is 85 kilos, BMI 29, creatinine 0.93. She tells you that her Glargine is 14 units at nighttime every night. She takes Lispro 6, 7, and 7 units AC before meals. Her correction factor is Lispro 2 units per every 50 when her blood sugar rises above 150 before meals, which means her correction factor really is 1 per 25. She was admitted for fever and chills, CFRD, CF exacerbation. She's eating very poorly, almost nothing at this time. The first day of data, once again, this is an actual patient. First day of data, you see that when she first came in, she had taken Glargine 14 units at home the night before. Her pre-lunch blood sugar is great, it's 148. And then her nighttime, bedtime blood sugar roses to 301. Probably, maybe she ate a little bit for dinner, or maybe she's having stress hyperglycemia from her fevers and CF exacerbation. What happened was that this patient was given half the dose of Glargine because she's not eating. And then she also received Lispro 3 units at bedtime. The next day's data, you see that despite patient not eating or eating minimally, her blood sugar is running in the low to mid 200s constantly. How would you manage this patient? How do you calculate how much basal insulin this patient needs? The answer is patient has received 10 units of insulin bedtime on the first night. Does the patient have a reasonable fasting blood sugar the next morning? The answer is no. So at the very, very minimum, you need to give this patient 10 units of Glargine at night, but 10 units is unlikely to be to suffice. Okay, and then you place this patient's total daily dose. So home regimen is 14 units plus 6 plus 7 plus 7. So total dose is 34 units. So she's kind of on the junction of low dose correction, falls in the low dose correction category, but then kind of on the cusp. Maybe she can be considered for medium correction. Given that she's not eating, maybe we'll start with low dose. You place all second day's blood sugar values on the low dose correction scale, and that gives you a +3 for the fasting blood sugar, +2 for pre-lunch, +2 for dinner. What you can do is you start with a base of 10 and then add the 3, add the 2, and add the 2. So that gives you 17 units. So a reasonable basal insulin will be between 10 units to 17 units. What I will probably do in her case is to just restart her home dose of 14 units, even if she's not eating, because she had a pre-lunch blood sugar that's really good on the first day, showing that her home dose is reasonable. So no rapid acting insulin because she's not eating. A more complicated case, 69-year-old female with type 2 diabetes complicated by peripheral neuropathy and also stage 4 CKD. Her home regimen is U300 Glargine to JO, 50 units in the morning, aspart 3 to 5 units. Really, she's taking 1 unit per 15 grams QAC. Her home total daily dose of insulin already puts her at 56 to 60 units a day. But she tells you that she frequently gets mild hypoglycemia in the morning in the 60s. So what does this tell you? Looking at her home regimen more closely, you see that her basal insulin is skewed significantly toward the basal. And then she's taking 50 units in form of basal, and then in the form of rapid acting, it's anywhere from 9 to 15 units a day only. So the reason she's having fasting hypoglycemia, or whenever she doesn't eat, she gets hypoglycemic, is because her basal is too high. Okay, so now that you have made this assessment, the next thing I typically look at is her weight is 75 kilos, and then her BMI is 27. So again, I say that I will put the basal insulin dose divided by kilogram of body weight. So if she's taking 50 units divided by 75 kilos, that actually puts her basal at 0.67 unit per kilo. That is a very high basal. Okay, so right away, for these two reasons, you know that her basal insulin needs to be decreased, especially when she's submitted on the inpatient side, when she may be made NPO for procedures. You definitely need to cut the basal insulin. So what doses would you recommend for her to take? I will tell you what I did for her. Once again, this is a true patient that I've managed. Here are her data. Okay, so on the first day, you see that even when she's eating, her blood sugar is frequently in the 80s, 85, and that is in the context of her having some residual steroid effect from 36 hours ago. So that's the only reason she's not hypoglycemic. And then on the second day, you see that her fasting blood sugar, again, is 85 and pre-lunch is 113. So what I did was that I took her total daily dose, cut it in half. Okay, so 60 units a day, half of that is 30 units. So I did not go down all the way to giving her only 30 units of Glargine. I gave her a little bit of a higher dose, 36 units. And you see that with her getting 36 units, her pre-lunch blood sugar remains really good. And the second thing that I did, if you're decreasing the basal that is covering the nutritional, then you must increase the nutritional insulin. At home, she's only using 1 per 15, which again doesn't make sense because we know that 1 per 15 is considered quote unquote low dose. So I made her an intermediate carb ratio dose, which is 1 per 10. And then you see that her blood sugar is well managed. At the time of her discharge, so I didn't manage her for very long and she needs to go home. I put her on 2JO, 30 units QAM, which is equivalent to 0.4 unit per kilo, 1 per 10 carbs AC. So if she eats a reasonable amount, 75 grams per meal, that will give her 23 units in a day. So now that her basal to nutritional ratio is a lot more reasonable at 57 to 43% distribution. And then I put her on medium dose correction ACHS. All right, so we have about 2 minutes to cover IV to subQ insulin. I can cover the basic concept, but won't be able to go over the cases. So what you need to do this transition is you need a good 6 to 8 hours of blood sugar data and IV insulin infusion rates when the patient's not eating at all because you're trying to estimate the basal insulin need. And then you also need all of the blood sugar values in the target range of 100 to 180 in the 6 to 8 hours. 24-hour basal calculation is for the 6 to 8 hours, you add up all the insulin units infused from the IV insulin divided by the total hours that lapsed. And then that gives you the unit per hour rate. You then multiply that by 24 hours for a 24-hour requirement. So now that you have a 24-hour requirement, you will then need to decide whether you want to take a 20% reduction or not. That's what the point A is. Okay, so if patients are getting D5 at 100 cc an hour, that is the standard 20% reduction or the multiplying by 0.8. So anything equivalent to D5 at 100 cc per hour, for example, D10 at 50 cc an hour. Okay, so anything like that, 20% dose reduction. You need to consider additional factors that can change your decision about how much basal insulin to give. So, for example, if patient definitely is having decreased surgical stress because he or she is further away from the surgical date, then you probably want to take a greater reduction. If patient has received a large dose of steroid and its effect is actively waning, then you need to take a greater reduction. D5, D10 we talked about. If patient's highly insulin sensitive at baseline or is elderly with a loose glycemic target, then you want to take a greater reduction. And also, there are patients who are extremely insulin resistant, defined as needing greater than 1 unit per kilogram of insulin of body weight. You need to be very cautious about this transition because oftentimes these are the really difficult patients to manage. So, depending on these factors, that kind of offset the balance. You then make a decision to multiply your 24-hour total insulin, basal insulin, by anywhere between 60 to 90% for this transition. And then you need to make sure to overlap your IV insulin with your sub-Q basal insulin by at least 2 hours to allow the sub-Q insulin to go into effect before turning off the IV insulin. So I have a very quick example. So the best time period to transition this patient is box B, where you see the lowest rate at 1 unit per hour for 6 hours or so. And patient's blood sugar is very well controlled, and patients not eating during that time, and patients is getting D5 at 100 cc per hour. The calculation would be 1 unit per hour times 24 hours, which is 24 units. You take a 20% dose reduction, multiply by 80%, and you will transition using 19 to 20 units of basal glargine, overlap with the drip for 2 hours, and turn off the drip. So at this point, I will conclude my talk here. I'm sorry I didn't get into the last few examples that I have, but if anyone wants to ask question or stay, I'm happy to stay for questions.
Hi, Dr. Chao. Thank you so much. This is Tanya Rizzo again. We really appreciate your expertise. I'm not sure if you can see some of the questions, but one in general, which is a common one, is there at any point with dosing, for example, if you're greater than 60 units, do you divide the dosing into 2 injections? Like, do you have an amount where you do that?
Yes. So whenever you're giving an injection of insulin that is 60 units or greater, I split that into 2 doses of insulin to be injected simultaneously. This most often applies to basal insulin, even though I have had a few patients on the inpatient side who requires the splitting of nutritional insulin as well. Great question. And the reason for that is because once you have a really large amount of insulin in a single injection, first of all, it's painful to inject such a large amount. Second of all, when you have a depot of insulin, such a big depot sitting underneath the skin, it's not going to be readily absorbed. And that creates an unpredictable absorption, leading to erratic blood sugar patterns.
A personal question of mine, I've certainly seen some articles where many hospital systems are starting to implement continuous blood glucose monitoring systems on the inpatient side. Have you at the U, or do you plan on it?
So this question became extremely relevant due to the pandemic because one concern about COVID patients is that nurses will need to go into their room to check their blood sugar, especially if they're placed on IV insulin, and that could create a lot of exposure and use of the personal protective equipment. So there has been studies done on the Dexcom. I think the study may still be ongoing or may have concluded just recently. In general, I think people have made the exception to start using the Dexcom, and then later on. So FDA actually has approved for emergent use of Dexcom in the hospital, followed by emergent use of the Libre in the hospital, because of the pandemic, but I believe that we still need additional data to gauge the safety of using the CGM inpatient. In fact, Dr. Earl Hirsch at University of Washington is planning on inpatient study using the Dexcom in the coming summer/fall, and I'll be helping out with that study to gauge the safety. And some big questions we have is that in patients who are in the ICU critically ill with diminished peripheral circulation, as well as patients undergoing anesthesia in the operating room, it seems that there are data to suggest that the blood sugar obtained from the CGM may not be entirely accurate. So that poses some safety concerns that need to be evaluated.
Another question I have is, if you are for some reason initiating an SGLT2 or the GLP-1s, how do you handle that for the outpatient providers? Do you get insurance coverage to ensure that they'll be able to continue? And if so, who does that? Pharmacy, a provider?
So as an endocrinologist, I rarely initiate SGLT2 inhibitor, much less so GLP-1 receptor agonist on the inpatient side. I generally will start them on the outpatient side, especially in patients who are deemed high risk for cardiovascular complications or renal complications. Those clinicians who are actively starting the SGLT2 inhibitors in the hospital are the cardiologists, and maybe we'll start seeing nephrologists doing that more often as well. But cardiologists on the heart failure service by far are the most frequent prescribers of SGLT2 inhibitors inpatient. So they will have to make sure that the patient's insurance will pay for these medications, because you're absolutely right. Those are really, really expensive if the insurance coverage is not good. Even if there's insurance coverage, sometimes patients still need to pay several $100s out of pocket. So that may not be affordable for many of them. So I want to clarify. So there is a comment from MedPeds residents saying that I'm a little bit confused about why sole use of SSI is bad, since we tend to do this on the inpatient side. When you, even if you engage in a quote unquote common practice, it doesn't mean that common practice is the right thing to do. So there's plenty of evidence and data showing that the sole use of SSI sliding scale insulin is discouraged or not optimal. So once again, the differentiation between a SSI sliding scale versus correctional insulin is whether the treating clinicians are assuming an active versus passive role in designing the insulin regimen. The reason, once again, SSI is not encouraged is because it suggests that you'll prescribe a strength of sliding scale and kind of just never go back to review patients' blood sugar anymore or adjust patients' insulin actively by incorporating the correction doses needed to make a standing MDI regimen or fixed doses of insulin. And that's why we differentiate between sliding scale versus correctional insulin, where you take a more active role.
And I think one last question. I personally haven't seen a lot of U500 used very much anymore, and we would sometimes continue it on the inpatient side when it was. Is that something that has just become more obsolete, or do you leave patients on U500 if you are seeing a rare patient with it?
Contrary to your experience, I have seen a very significant rise in the number of patients using U500 at the University of Washington Mount Lake campus. So I actually have poll data on the inpatient patients using U500. So compared to 3 or 4 years ago when I initially pulled the data, at that time we have a total of 10 to 12 patients using U500 inpatient in 1 year. Now we are seeing anywhere between 4 to 6 patients on U500 monthly. And there has been 1 week, actually May of last year, that I managed 4 or 5 patients on U500 in that week alone. The recommendation on U500, it is going to be hard to tell you what's the right thing to do in a very brief summary, but the most important thing is to clarify how the patient is taking the U500. Is this from a U100 syringe using a U500 vial, or are the patients taking the U500 using a U500 syringe or a U500 pen? This is the most important clarification to make with the patient, because when patients are using the U500 pen, insulin pen, or the U500 syringe, which has a green cap, the dose that's reported or seen on the syringe or pen is equivalent to the U100 dose. So in reality, when you report 1 unit of insulin, it is always 1 unit of insulin. In the past, we have said, okay, so if you're giving 10 units of U500, okay, let me think about how to say this correctly. So 10 units of U500 in a U100 syringe. So we know that the U500 volume is 5 times smaller, and that's why when patients are highly insulin resistant, it is optimal to shrink the amount of volume to lead to better absorption, and thus U500. So in general, 100 units of U100 is equivalent to 1 milliliter, and then 100 units of U500 is a fifth of that, which is 20 milliliter. So the amount of if you're talking about the same number of units and drawn up as U500 in the U100 syringe, the number of units seen on the U100 syringe will be 5 times less. Okay, so I think that's the best way to answer that. And you just need to clarify how the patient is taking the insulin to make sure that you know the actual number of units that patients are administering, because this is the most frequent mistake made. If you make this mistake, the amount of insulin you're dispensing will be 5 times different. And then the next thing is you need to assess how well patients control it at home, and then based on that, as well as whether patients are eating inpatient, you will then need to make the finer adjustment of the U500 regimen inpatient.
Well, many thanks again. And if there are any follow-up questions, please let me know and I can reach out to Dr. Chao. But we appreciate the time spent on an important topic.
Great. I have a question for Valley Medical Center in general. My understanding is that you guys don't have an inpatient glycemic consult team, right?
That's correct. That's why this is very helpful. We do have a new order set that does emphasize not using only sliding scale and trying to, that walks through different scenarios. But most of this is hospitalist driven.
Yeah, at UWMC and Harborview and Northwest, we have recently transitioned to Inpatient Epic. Is that also what you're using at Valley?
Yes, since 2011.
Okay, because I do think that there may be effort to make the inpatient insulin orders the same across UW Medicine. So I just don't know if that has happened already.
That's a good question. Chris Eaton, one of our hospitalists, worked on the order set, and I would frequently we build them off of the use, or at least with their input. And so I'll have to reach out to him to see what he used.
Great. Okay. Well, thank
and
you.
I'll share that with you and link you up with him. Okay.
That sounds great.
Okay.
Thank you all.